Hello, and welcome to the Lymphedema webinar series. My name is Joanne Yao, and I am the Vice President of Marketing with Lymphedema. Today's webinar is titled L-Dex101, Understand, Interpret, and Incorporate the SOZO L-Dex analysis for lymphedema into your practice. March is Lymphedema Awareness Month, and we want to recognize the patients, caregivers, and advocates working to improve the lives of millions of lymphedema patients worldwide. ImpediMed has a long history in lymphedema care with both novel technology and in clinical studies. And today you will hear from 3 panelists who have been instrumental to this journey. They're innovators in the care of lymphedema patients and preventing chronic lymphedema in cancer patients. We have Louise Kohlmeyer, PhD, occupational therapist and lymphedema therapist, Director and Senior Lecturer in the Australian Lymphedema Education Research and Treatment Program at Macquarie University in Australia. We have Sarah Coddington, Doctor of Physical Therapy and Certified Lymphedema Therapist with Baptist Health Louisville in the United States, and Catherine Kingsford, the Senior Vice President of Medical Affairs with ImpediMed. We look forward to our webinar today. We're going to have a panel discussion, and we welcome your questions. You may participate by submitting questions via the Q&A icon on your screen at any time. We will answer as many questions as possible during the next hour, and we'll follow up on any questions that we're not able to address live. We're also happy to offer certificates of completion for your participation in this webinar upon request. To request a certificate, you may either respond to your registration confirmation email us at info@impedimed.com, or contact your ImpediMed representative. All of our webinars are available for replay approximately 1 week following the event, and you may find them on ImpediMed's Oncology YouTube channel. Please subscribe while you're there. So now I would like to invite Louise, Sarah, and Kathy to join me on video. Hi, everybody. Thank you for joining me today. We're very excited to have you here participating in the webinar. We have a wonderful event lined up today and are excited to start with introductions. So I introduced myself. I'm the Vice President of Marketing with ImpediMed, joined by a wonderful group of panelists. And Louise, why don't you go ahead and go first and introduce a little bit about who you are in your practice.
Thanks, Joanne. Hi, everyone, and happy Lymphedema Awareness Month. And thanks to ImpediMed and the team for inviting me to participate in this webinar. I'm an occupational therapist and lymphedema therapist with over 30 years experience working in this area. My practice changed when I was introduced to the ImpediMed technology, bioimpedance technology in the early 2000s. And it certainly changed the way I worked. I'm very passionate about early intervention and the prospective surveillance model of care. I run a program here at Macquarie University in Sydney where we were privileged to be part of the big international PREVENT study. So I've been following this journey of this model of care for a long time. So really glad to be here today.
Thank you, Louise. We're super excited to have you join us. And Sarah, would you please introduce yourself, a little bit about who you are in your practice?
Hi, I'm Sarah Coddington. I am a physical therapist out of Louisville, Kentucky. I have been practicing here about almost 13 years, and I have been doing lymphedema care specific to breast cancer the entire time. And just like Louise said, I 100% agree that the bioimpedance has changed our practice and the way I treat our patients. And we focus on early intervention model of care for our patients. I think that's the big things. I'm excited to be here and I can't wait to hear all your questions. So.
Thanks, Sarah. We're very happy to have you join us. And Kathy, would you please share a little bit about your background and your role with ImpediMed?
Sure. I'm Kathy Kingsford. I'm Senior Vice President of Medical Affairs for ImpediMed, which means I look after clinical trials and also regulatory affairs. That means I was with Louise through the PREVENT trial. We started back in 2014, and I worked with all of the sites across the US and Australia to get to our exciting endpoint. And I've also had the privilege of working for ImpediMed for 15 years. I've worked in both the Brisbane Australian office and the San Diego Carlsbad US office. And prior to ImpediMed, I was a clinician. I was a cardiac scientist working in implantable devices. So I'm very happy to be here and privileged to be with the other two ladies. Thank you.
Thanks, Kathy. We're really happy to have you join us because today's webinar is very different from what we've done before because it's all about L-Dex. And to give everybody an idea of how much interest there is in this topic, we actually had record registration with over 400 registrants for this event. Now we have a lot of people online, so there's a lot of interest in what we're talking about here. We are going to, we've compiled a list of all the key topics that have been coming through and the questions that have come through to us over the years about L-Dex, really about how do you understand it, interpret it, and put it into practice. And so we're going to cover all those topics today. Of course, submit questions anytime. Some people submitted questions in advance. We have those and we will address them. So let's start with some of the history here because Kathy, I know you've been working with L-Dex for, as you said, you've been with ImpediMed for almost 15 years. So could you give us a little bit of the history behind L-Dex? Why was it developed? How did it come to be what it is today?
Sure, thanks, Joanne. So bioimpedance spectroscopy, as we know it, is a technology that was always used to look at body composition and fluid levels within the body. And so in the late 80s, there were 3 professors here in Brisbane out of the University of Queensland and the Queensland University of Technology that had a friend who was actually undergoing cancer treatment himself. And he was in the cancer clinic and he was seeing these women walk in with a swollen arm and sort of asked and said, what's going on? And they said, oh, they're breast cancer survivors. They have this condition called lymphedema. And he said, what's that? And it, explained that it was an accumulation of fluid. So he went back to these 3 guys and said, hey, you've got this device that measures fluid. Can you do something to help these women? And so that's really how the premise was born of using bioimpedance to measure fluid in breast cancer survivors. So being scientists, they looked at the ratio of an arm to compare what was a healthy limb to an unhealthy limb and came up with these great reference ranges. And Louise will smile because, if your at-risk limb was dominant, the mean for that reference range was 1.037. And if your non-dominant limb was the one at risk, the mean was 0.964. And if you want to look at a 3 standard deviation change, you take your measurement, you get your ratio, and you add 0.102 to it to see whether you've reached that threshold of 3 standard deviations. And that just got a little complicated for clinicians, and I can speak for Louise because people's eyes used to roll and say, how do we make this clinically relevant? So we took those ratios and just created a simple linear scale that was a -10 to 10. So it didn't matter. You needed to tell the device what limb was dominant, whether it was the at-risk limb or not. But you didn't need to worry about that in your calculation. It was all done for you behind the scenes. And then when we expanded to other genders, like we included male and we included legs and then bilateral, L-Dex still remained that one scale of -10 to +10, regardless of what limb was at risk and what gender you were. So it was all that science, 3 decimal places was taken out of it, and we created the L-Dex scale to make it more clinically friendly.
Thank you, Kathy. I mean, it's clearly a long development history with a lot of collaboration with clinicians, including folks like Louise, who's on the call, and I know Sarah, you used the U400 prior to using the current SOZO device. So Louise, would you start a little bit with how you're using L-Dex today?
Sure, and I might add there, Joanne, following from what Kathy has said, I was one of those clinicians who went to these conferences, hearing these professors talk about this technology, and I was young then and thought, this seems really important. I need to understand this, but it was a little bit over my head. I do understand the science now though, but when the technology changed or when the information changed to be more clinically relevant and the L-Dex score with a number that I could then explain to my patients, it became much more exciting and much more relevant for me to use in clinical care. So I do use L-Dex as a tool in my toolbox for the assessment of patients that I see with all types and stages of lymphedema. I actually don't just use it in the prospective surveillance model of care. That is a large part of my practice and of our practice here at Macquarie University, but I do use L-Dex across the whole spectrum. And I think the key is that as a clinician, we have to use evidence-based practice, and we don't just rely on one tool or one assessment to assess all types and stages of lymphedema. But L-Dex for me has been a very valuable tool in my toolbox in relation to person-centered care, in relation to educating and empowering my patients to feel like they're in control. And I have patients that perhaps had seen another therapist elsewhere and hadn't had an L-Dex reading previously, and they actually feel really ripped off when they hadn't had the L-Dex technology from the beginning of their cancer journey. So I use it from the beginning of someone's cancer journey at regular monitoring periods throughout their cancer treatment and beyond. But I also use the L-Dex technology for patients who do have clinical lymphedema. But I think, as we'll talk later on, you need to understand how to interpret the technology in the L-Dex score when you're using it with all stages of lymphedema.
No, and we're going to talk about that absolutely, and the difference in interpreting it in the prospective surveillance model of care versus in care of a chronic lymphedema patient. And Sarah, if you think about how Louise said she's using L-Dex, is that similar to your practice, or how do you approach using the tool?
Yes, 100%. It's very similar. We use it as part of our patient care. So we are clinical therapists. I'm a physical therapist here in Louisville, Kentucky, and there are 2 of us PTs and 1 occupational therapist that use the bioimpedance as a team. We do mostly use it for breast cancer treatment. At this time, it's probably 95% of what we use the L-Dex score for. We use it actually very closely to the ImpediMed protocol that we attempt as best as we can. We like to see patients from the moment they are diagnosed and get a preoperative score if possible, and see them, like Louise said, through their cancer journey. So we do try to see them post-operatively, through chemo, through radiation, through reconstruction, and then some. I have some patients I have actually been running the L-Dex on since 2012. So we do like to closely follow with our patients and do long-term care with them. We definitely use it as a tool in our toolbox that we can use it for early intervention, for treatment, for management, for the different stages based off what we are diagnosing them as the different stages. However, I really like to use it kind of like Louise said, that they kind of feel gypped if they didn't get it. They came from somewhere else and now they're getting it. It's like this extra thing. I just love to have it that I use it as what I call the peace of mind. So I may not see a patient for every 3 months, every 6 months, occasionally yearly. We try to at least do every 6 months. But it's one of those peace of mind that your arm it's doing okay and it has relearned how to work and it is working as your other arm is, and things are going well, and it does give them that peace of mind, and it really empowers the patient, especially if you're using it for that early intervention or prevention. And we don't like to use that word for insurance purposes, but for the early intervention for those patients. And I really do feel like it just really elevates that patient care.
So Sarah, it's interesting because one of the questions we get a lot is, what is L-Dex, right? It's the start of understanding it. What is L-Dex? And we also get asked, how do I describe it to a patient? So, you're discussing it with your patients. How do you describe what L-Dex is to your patients?
So for me personally, I keep it as basic as possible, because when you start throwing science, like Kathy was a second ago, giving lots of numbers, patients are already very overwhelmed. They have a cancer diagnosis, they're having surgery, they're having chemo, they're having radiation, they have 400 appointments they have to go to, and you are one more thing. And so I try to keep things as basic and as simple as possible unless they start to ask more questions. And I just say, this is a tool that uses technology to determine how the fluid is doing in your arms or in your legs, depending on what you're using it for. But typically mine is for the arms. And we're just going to compare how you're doing after surgery. Is there any fluid retention or any fluid buildup? What I love about this device, and I will even say that to the patients, what I love about using this device is that it can detect the earliest stages of fluid buildup before we can visibly see it, sometimes before you can physically even feel it. And it can really guide us in our treatment and giving you the best proper care that you can get. So that's kind of, and then I kind of leave it at that. And I'm like, here's your score. It's a good score. Or if it's not, what we're going to do. And I just try to really keep it basic for the patients.
And Louise, is your approach similar with patients? And then is it different if you're talking to another healthcare professional?
Sure, I totally support what Sarah said with keeping the education simple for patients, but I term my education as a drip filtering of education, like your drip filter coffee machine, that when you first see someone when they're first diagnosed with cancer, lymphedema isn't a priority for that individual. They want to know, am I going to live or die with this cancer diagnosis? Am I going to see my son go to school? Am I going to see my daughter graduate or get married? For them at that time, when we're ideally wanting to see these individuals, it's at a highly stressful time. And so I don't talk a lot about lymphedema at that point. I do similar education to what Sarah is saying, that we just want to monitor the fluid in your arms, and we'll get to know each other over time and continue to take these measurements. And that's usually enough to satisfy them. They feel like someone's listening to them, and aware of sort of the psychosocial and other factors that are going on for that individual at that time. And then as you do get to know them, and as part of the cancer rehabilitation journey, then you can build their knowledge, because they can be your advocates also in promoting the technology and this model of care. I call it more a model of care rather than just using a device to measure the fluid, that they can then be advocates to educate their own health professionals and other members of the multidisciplinary team. So drip filtering of education to patients, simple terms like Sarah's saying, and then build that knowledge as they have space to be able to take on more knowledge. And I guess in relation to health professionals, we as lymphedema therapists are the key people to be able to educate the members of the multidisciplinary team in this model of care. And yes, we do have to use more of the scientific language and more of the research data to be able to show the medicos and other individuals on the healthcare team what we're talking about, because this is really important. And really this model of care needs to be owned by the multidisciplinary team, not just necessarily the lymphedema therapist down in the little physiotherapy room. It needs to be owned by the multidisciplinary team, because lymphedema is a survivorship issue, and we want to reduce this for long-term patients. And we know that there's lots of myths out there about this condition from the past. Surgeries change, chemotherapies change, radiotherapies change, risk factors for lymphedema have changed. And we need to be up on the latest evidence to know who is at higher risk or lower risk, because when it comes to it, we might have to think about, risk stratification for our patients of who gets access to this service.
Thank you. Thank you, Louise. Now, Kathy, I'm going to ask you as the scientist, if someone asks you, how do you answer, what is L-Dex?
Yeah, I very much try to keep things simple too. I try not to be too sciencey, sorry. But I just say it's a tool we use to look for fluid as it's building up in the arm, and that we use, if you're talking about breast cancer patients, but we use the at-risk limb to compare to the non-at-risk limb. So we look at really what's going on within you yourself to be the control, and we look for those earliest signs of fluid buildup. And I do say that we pass a small electrical current through the body. I've got to get the sciencey bit in there a little bit, but yeah, again, try and keep it simple.
So let's dig into some of the specific questions about understanding L-Dex. What's the difference between unilateral and bilateral? And I'll let you start with that, Kathy, and then I'll go to Louise and Sarah.
So before, when I was saying about the ratios, the premise of L-Dex is to compare your at-risk limb with a healthy control, and that way, and we'll talk about this a little bit more later too, but that way we take into account what's going on within the body. So if you have if you're at risk with just one arm, we compare your at-risk arm to your non-at-risk arm. If you have gynecological cancer, then both legs would be at risk. So we can't compare one leg to the other. We compare a leg to an arm. So when you then convert that to the L-Dex, we were talking before about ratios to 3 decimal places. Sorry, I will get sciencey. The ratio between an arm and an arm is nearly 1 because they're very similar. When you look at your leg compared to your arm, it's not that similar. So we get a bit of a difference between that ratio. But in the L-Dex score, we still take into account that change. So the 6.5 is still valid. That change from baseline is still the same and still valid because we're still using that same theory of comparing a healthy limb to an unhealthy limb and seeing what the difference is.
So Louie, what parts of the body can be tested with L-Dex? We just got a question, does it work for chest and breast lymphedema? What are we talking about anatomically here?
So when we're talking about measuring L-Dex at this point in time, using the SOZO technology, we're looking at limbs, so arms and legs, both unilateral and upper and low, unilateral and bilateral limbs. So, and I think, you know, I've seen advances in the technology that at one stage we were only able to measure unilateral. And so you had to know which limb did you put in as the at risk. And so if the L-Dex was going up, something was happening to the at-risk limb, building up of extracellular fluid. If the reading was going down, then potentially there might have been something happening in the other limb. But, you know, we have these advances now that we can do bilateral by changing the profile in the patient. You don't actually lose other data in the device that you've already collected, and it can actually change to then collecting future measurements for bilateral limbs, which is useful sometimes when you may get an individual who's had a breast cancer 10 years ago, may or may not have had L-Dex back then, and then now comes with the new presentation of cancer on the other side. You can actually put in for a bilateral measurement and then be able to monitor both limbs moving forward.
And that's because SOZO captures all the data, every measurement. So if you need to change from unilateral to bilateral because the patient situation changed, it will back calculate all those prior measurements. Now,
Correct.
Sarah, another question we get a lot as far as kind of understanding what L-Dex is you talked about, you tell patients it measures fluid. How do you know it's measuring lymphedema versus other types of edema? Can it differentiate?
So not as much. That does make it more tricky. And that's where your clinical experience and judgment plays a very large key. So I do have to say, I might kind of look at things differently if someone is getting chemo, especially a taxane, or if they're getting radiation, or depending on what's going on in their situation, do they have an infection right now? Are they on an antibiotic? All of that can change your fluid levels. And so that can affect your score. So you really want to get as much data and information on the patient that you can, and using your clinical judgment. I mean, if the score is elevated and they've come in and they have some pitting edema and some symptoms, you've obviously able to track your treatment better that way. So that's where it is important to know your patient and not just run the score and get a score. You need to know what's going on in the patient's life and their treatment and what's happening at that time.
Mm-hmm.
And can I say, Joanne, I totally agree with what Sarah's saying there, that it's what I find most useful is not just the one individual score, but it's looking at trending over time and consideration to what the individual is going through in their life, whether it's their intensive treatment. They might have some post-surgical edema, which is not lymphedema, but you will see an elevation in the L-Dex score. So it's a tool in the toolbox to assess, but as lymphedema therapists, we need to complete our full assessment considering all of these other things as well.
Mm-hmm. So let's talk about common questions about how to interpret L-Dex. And I'm going to ask Lisa to go ahead and put up the L-Dex scale for this portion of the conversation. So, you know, Kathy talked about L-Dex, and there's plus or minus 10 for the normal range. So an L-Dex score is plotted on the scale. The average is 0, and then plus or minus 10 is the normal range. And we also have this yellow intermediate range as well. So You know, Sarah, when you test a patient for the first time, how do you know their L-Dex score is normal or abnormal?
So optimally, goal of LDex is to see the patient preoperatively and establish what is their normal or their baseline score, and then to rerun it 8, 12, 16 weeks after that, depending on drains and how they're healing, and kind of just see how are they doing. Sometimes that doesn't happen. That life is not perfect and we don't always get the optimal thing. So I personally, and I think Louise would say the same thing, the more data that you can get, the better. So I may run the score more frequently at first to obtain more data on the patient and determine what is their normal, or if there is something going on. If I have a patient that I'm seeing pretty regularly and their scores bumping up and down and drastically changing weekly, monthly, to me, that indicates instability in their system. If it's pretty stable and it's staying the same at all times and they're not having really any symptoms, that lets me know they're doing pretty well. And so that can let me know, is this a normal for them or not? So sometimes you just need more data on the patient.
Mm-hmm. And Louise, if you're following a patient and let's say you didn't get that opportunity to get a pre-treatment baseline, and you see that patient after their treatment started, say 3 months, and that their first L-Dex score is, say, in that yellow intermediate range, say 6.8, 6.9, how do you interpret that?
Good question, Joanne. I totally support, again, what Sarah says. We're on the same page here today, Sarah, across the other side of the world. I would say, like you just did, Joanne, pre-treatment measurements rather than just pre-surgery, because these days, I know in Australia, we're seeing a lot more neoadjuvant chemotherapy happening. So ideally, we want to try to take a reading before for any treatment if possible, but I know that doesn't always happen. So we often get patients who come after surgery or after they've started treatment, and they may have a slightly higher L-Dex score. That is, the first one that we're seeing. I would certainly not be rushing into putting someone into compression therapy. If they had a reading of 6.8, that's potentially still in the normal range and could be exactly what they were before they started treatment. So again, it's part of your understanding and your education to your patient about listening. Are they feeling any symptoms? Are they feeling any heaviness or fullness in their arm? And most likely they're not with that sort of score. And so potentially what you could do is offer to see them in a 4-week period after you've seen them for that first time, if you're concerned that maybe it's a higher reading, to just check, is that relatively normal or stable for them? But I certainly am a little bit cautious putting someone in a Garmin if it's the first time I've seen them and I don't know sort of a lot of history about them. Unless they're reporting symptoms, I would possibly want to see them sooner than the 3-month monitoring period.
Mm-hmm. So, it's interesting because we're talking about, the use of L-Dex to track a patient going through cancer treatment to detect lymphedema and then managing chronic lymphedema patients. Is the reference range different depending on if it's a patient that has not yet developed chronic lymphedema versus the patient that has?
Do you want me to take that?
Okay, Kathy, you have a go.
The reference range is based on healthy individuals. So the reference range does not change. And I will say something that maybe the clinicians hopefully will agree with, but from a clinical standpoint, it's the same with if you look at obesity and things like that. You may never be able to get a very obese person back down into the normal, what a normal BMI or a normal healthy range. So you may actually strive to get that patient who has a higher L-Dex down, but may never get back down to within the normal range if they're more advanced. So, but the reference range itself never changes because of the fact it's based on normal healthy individuals.
So what does it mean to have a negative L-Dex, Kathy?
It means that there's more fluid in your healthy arm. So I can talk about a case we had back in, I think it was 2008, where we got a call from a clinician and said, my patient was tracking along really, really well, but now their L-Dex has gone to -11 or thereabouts. And I was like, okay, what's going on with the patient? So I said I came from a cardiology background. It's always what's going on with the patient. And they said, well, they've got cellulitis in their healthy, control arm. So they've got fluid building up in their healthy control arm. So there's fluid building up. And so that was really a sign that you should be looking at the whole patient. But a negative L-Dex is likely in half of your patients anyway, because if we're looking at just the reference range of -10 to +10, half of your patients have to be in the -10 to 0, just the way the statistics work. So a negative L-Dex is not necessarily a bad thing. And it really is dependent on really what's going on with your healthy control arm. So I'm not going to stand up and show you my arms now, but I know people have seen my right arm is really quite has an angle at the elbow different to my left arm. So my baseline L-Dex, if I say my right arm is at risk, is -5.5. And it has been for years. It is unchanged. So it really is what's going on with the patient and really understanding that. But if you're getting a negative, so if you're getting negative at baseline, it might be to do with anatomy. If you are positive and go negative, you need to look at what's going on with that healthy arm, because the healthy arm may not be healthy anymore. Do you agree, Louise?
Yes, and I've had another patient too that I've shared with you, Kathy, that came to me, was tracking beautifully and nice and stable, and then came in with a significant reduction in the L-Dex into the negatives as well. And again, looking at the whole person, she had a phlebitis in her unaffected arm from where they were giving her chemotherapy, and so had a buildup of extracellular fluid. So the reading went from +3 to -10, and it was because of something happening in the unaffected limb rather than her breast cancer side. So that's where, as lymphedema therapists, I say this technology is a dumb box, it's a dumb machine. We, as the health professionals, have to understand how to utilize it and understand the technology in order to be able to educate our patients in what the results are telling us.
Because another, Sarah, thank you, Louise and Kathy, because the other thing we hear is that, my patient has chronic lymphedema, that's visible chronic lymphedema with fibrotic changes. Why is their L-Dex score going down? So do you have any experience with that, Sarah?
Kind of a little bit of both, actually. So if I have a stage 2 fibrotic true lymphedema patient that comes in and they want to get better, that'll usually what I came in because I want to get treatment and I want to get better. If I'm going to use L-Dex on that patient, I have actually found that when I initiate treatment with what you would do, bandaging, massage, compression, all the different treatments you would do, I actually see their score go up at first. And I will warn them of that. And I don't know all the science behind it, Kathy, like you might have to kind of help me out. But I think it's because we're actually like opening pathways and getting the fluid moving. And so it's agitating the system and it goes up. And then once you're stabilizing their system and the treatment is effective for them, be it that you get them stable and they have new compression and you're keeping them stable, or it's slightly improving and getting better, then I will see the scoring going down or at least staying stable. So I am a little hesitant to use L-Dex or even show my patients L-Dex if I'm treating true lymphedema and I'm in the midst of treatment, because I actually see their score go up. So I don't know if you have that happen, Louise, if you've noticed that. So a lot of times, if I'm truly treating the patient and I'm giving them 8 to 12 weeks of treatment, I won't run their L-Dex during that time. Or if I do, I may not let them know what's going on and I use it for myself. Because I tend to see that more than the going down unless they've stabilized or they're improving.
Yes, I've had that experience all the time. And I just use it in talking to my patients that if they've got a fibrotic limb and we want to do an intensive complex lymphedema treatment with manual lymphatic drainage and bandaging exercise, that it's likely that the L-Dex will go up. And that's what I hope, because I'm wanting to change the tissue, reduce the fibrosis, increase extracellular fluid, And then when we get going with good compression and into a good compression garment, we usually find the L-Dex then comes down. So that's not a common thing, and we educate our patients in that before we do treatment. And interestingly, we do liposuction surgery here at Macquarie University using Professor Brawson's protocol. And one of our criteria is that we have to have minimal amount of fluid. So we want our patients to have a low L-Dex, because we want to have gotten all the fluid out of the limb before we go and operate to remove the fatty adipose tissue. So our liposuction patients will often have a low L-Dex, high volume difference, and then we actually see post-operative swelling, so an increase in the L-Dex after liposuction surgery, and then it goes down. So again, we need to understand what this technology is measuring and then how we explain it to our patients.
And I think let's spend a little bit of time talking about what impacts an L-Dex measurement. We get a lot of questions there, but before we do, and this will help the conversation, is we have a question in the Q&A of how is L-Dex calculated? So in your simplest terms, Kathy, challenge, you know, how is L-Dex calculated?
Well, it is simply, as I said earlier, it is just a ratio of the R0 value, so the impedance at the lowest frequency we can calculate, and that is assuming that all of the electrical current, as I said, we do pass an electrical current through the body, all of the electrical current is going through the extracellular space only at that time. So we take that value of your at-risk limb and at your un-at-risk limb, non-at-risk limb, and we have a ratio, and we put the at-risk limb as the denominator, so that as fluid builds, L-Dex goes up. And there is some, the reference range and the standard deviations are all included in that calculation. But it's truly just, if you took a ratio and put it on the same graph as an L-Dex, you would have the same shape graph. The values would be different, but the graph would be exactly the same. So it's absolutely a linear calculation for that. So yeah, we compare an at-risk limb to a healthy limb.
Mm-hmm. Yeah, so we're measuring the resistance of the extracellular fluid and then using that ratio in the two limbs. So keeping that in mind, let's talk a little bit about factors that impact an L-Dex measurement. So Sarah, you know, when you are thinking about taking a high quality L-Dex measurement, what is your standard practice? What do you try to achieve to get, you know, the most consistent results out of SOZO?
So we have a handout that we give our patients, and I try to remind them each time they come. I have to say, we used to be really good about calling them before they came for the very first visit, but we definitely get it for their following visits. But we try to do no caffeine at least 2 hours before, no exercise. We try to have them void their bowel and bladder right immediately before the test. I do like to actually clean the machine right before and have it a little bit damp. We use like a diaper wipe or a water wipe just to have it just a little bit damp. We make sure that they have clean hands and clean feet. I definitely have patients that when they take their socks off, they have sock fuzzies. That can definitely affect the score. So I try to make sure that their feet are nice and clean. We attempt to do the same time of the day. Luckily, most of my patients either want to be morning people or afternoon people, so time of day can play a factor. I think those are the big things. I'm probably forgetting something, but I think those are the biggies.
Louise, what about your practice? And let me ask you this. Do you ever take two L-Dex scores in a row just to make sure they're the same?
Generally not. No, I unless I'm concerned with the reading. If there's something that concerns me, or if it comes up with, you know, medium quality, I might decide to do that. And most of the time it's dampening the base of the feet and hands. And I certainly do what Sarah says in cleaning and wiping the plates, the hand and foot plates before using. That's also a good sign to patients that you're using your infection control as well, which I think these days, particularly with COVID, but you know, we should be doing that all the time. But I think I always do that in front of the patient and then having it still being damp. So I don't generally take a second measure But you know, I have done research where we've done a validation study of doing 3 repeat measurements of the SOZO, one after the other, and our reliability was very strong. So I don't tend to do it repeat measures with patients in front of me.
Now, what about if they're wearing compression garments? How do you handle, you know, how long should they be removed prior to taking a measurement? And how does that impact the output?
Yeah, so if it's just routine clinical practice, most of my patients would either be wearing garments into the clinic or not wearing them in, and they tend to be creatures of habit. So patients, like Sarah said, do tend to book for morning appointments or afternoon appointments. So you're getting a similar time of day. And if they're coming straight from work, they're either going to have their garment on or not on. And so I will record if they're coming in and they've had their garment on or not on, just in case sometimes they may not, because that may fluctuate the reading. But as far as the timing for taking the garment off before I measure, usually it's just take the garment off and then we measure. But if I'm doing that and I'm doing that routinely, then I should be getting a similar measure each time with that time frame. Like in formal research studies, you may elect to have a specific amount of time without the garment on before you take the measure. But in routine clinical practice, you've got to make it work for your clinical flow.
Mm-hmm.
Can I add to that really quick?
Yeah, absolutely.
Sometimes it depends on what my goal is for the patient. So say we were wearing compression preventatively for radiation, and they're now finished with radiation and they want to wean out of wearing the compression. So we use it for preventative technique, the compression for preventative techniques, specifically with radiation, some chemos. So say the patient is finished with radiation for 6 weeks and they're finished and they're doing well, their skin's healing well, they have no symptoms, and we want to wean out of the compression. I may have them purposely not wear their compression. I'll say, I want you to go all night and all morning without it on, and I want to get a reading and see where you're at. And then the next time I want to make sure you have not had it on for at least 24 hours before I get the reading. Now, if I'm doing the readings because they need to be in compression, then I'm not as concerned how long it's off because they need to be in compression. But if I am trying to get them out of compression, I'm going to do their readings differently, and I'm going to tell them. And a lot of times I'll even write on their reminder card for the next time that they come, how I want them to do it. So I don't know, Louise, if you guys use compression preventatively in that fashion. So you might use the L-Dex differently for that. If they happened to forget and they wore it in, I might try to have them out of it for 10 or 15 minutes and maybe do some of my subjective history just to kind of get a little bit of better data. But I don't want to do exercise or manual therapy during that time because that could affect the score. So it kind of depends on what I'm doing with the patient.
Yeah, good point, Sarah. And it just goes back to basic as a health professional, as a lymphedema therapist, person-centered care, goal-centered care, and offering best practice. So, you know, tools in our toolbox that we use for assessment and management, and we document them so that we can then monitor change over time.
And you know, you're talking about using the compression while the patient's undergoing radiation. We did get a question from the audience, which Kathy, you might be able to help. Is there any scientific literature that supports the benefit of using compression preventatively during radiation therapy?
Not that I'm aware of, but I will. I saw that question. I will have to look it up, but I can certainly get back to that. There's nothing that I'm aware of as far as prophylactic use during radiation therapy. Are you, Louise?
There was, so Kathy, there was a study published by the Sydney just by the Sydney University group, just published in the last month or so, where they did a trial of wearing prophylactic compression for the first 12 months during breast cancer treatment. So that would have included radiation,
but not specifically for radiation.
Not specifically for radiation.
I did see the paper, but not specifically for radiation. Yep.
And I think that's something we should be looking at. It was quite a large randomized controlled trial, so something to be aware of.
Interesting. And so let's talk about that, because we're talking a lot about use of L-Dex for early detection and intervention of cancer-related lymphedema, the prospective surveillance model of care. So Louise, would you do us the honors of describing what that protocol looks like in your practice, what you do to try and prevent chronic lymphedema or the development of chronic lymphedema in your cancer patients?
Sure, Joanne. So really it does mean implementing this model of care, which is a large component of education, using L-Dex monitoring. And if you ideally have a pre-treatment baseline, you're looking for a change of 6.5 L-Dex points increase from their baseline is when you would implement early intervention. And that early intervention and the results from the PREVENT study, the treatment that we used in that study was wearing a compression sleeve, a C2G sleeve with a gauntlet, a handpiece, wearing it for 12 hours a day, a 20 to 30 millimeter level of compression, and wearing it ideally for 28 days in that study. In my own clinical practice, I wouldn't usually just remove the sleeve after 28 days or 4 weeks. Generally, it's again dependent on what's happening with the patient, where they're at with their treatment, what time of year is it, the middle of summer, are they middle of chemotherapy or radiotherapy, and then at an appropriate time you would implement a weaning period of the sleeve, whether that's reducing number of hours per day of wearing the sleeve as a start, or potentially alternate days, and close monitoring during that period is generally what we would do.
Thank you. And Sarah, I know you use a similar model of care as well. Could you talk a little bit about baselines? We have questions. When do you take your baseline? What do you do if you can't get it before treatment? And do you take circumference measurements as well?
Yes. So optimally, I would love to get their baseline score at diagnosis. So before treatment, before surgery, that's ideal before anything happens to the patient. That doesn't always happen. The patients have a lot going on. And like Louise said, they're worried about, are they going to live and die? So coming to their therapy appointment to have that reading may not be their overall end all be all. But optimally, we would love to get it either preoperatively or pre-treatment if they're getting neoadjuvant chemo. And then we would reassess it. If I can get a pre-treatment, like pre-neoadjuvant, I like to then get a pre-op and then maybe like an 8 to 12 week post-op. But that doesn't always happen. Sometimes you get patients that they come in 4 weeks after surgery, or they come in, they still have drains in. And so you do really have to decide when is the optimal time to take it. So if they still have drains in, or if it's only been 4 weeks, I'm probably not going to take it that time. I'm going to educate them about it, but I'm going to wait until some of that post-operative fluid has decreased for sure. So at that point, 8 to 12 weeks post-op, depending on what all they had done, is a good time to run it. That doesn't always happen either. Sometimes they come in that they're 8 weeks out and they're starting chemo, or they've already started chemo, or they're going to start radiation. So it really depends. And I think that's where the clinical guidance with that is super important, and educating your patient. We're going to run this. It's going to give us some data, but we're also going to treat you based off what's going on with your body and how you're feeling. And then with that, the more data I can get. So I may run it at 8 weeks and it might be slightly elevated. So I might have them come back in 2 to 4 weeks. Whereas if I run it at 8 weeks and it's really good, I might run it again in another 8 to 12 weeks. So it really depends on the patient, their access to the clinic, how far are they driving to come in, what are their symptoms. So it is a tool in our toolbox, just like Louise said. You want to use it based off all of those different findings. I think you asked something else though that I was going to answer. What else did you ask me?
Are you taking circumference measurements?
Yes,
and how
thank you. That was the other thing.
Comparing
So
circumference to L-Dex?
Yes, I do actually. I do still take circumference measurements, especially if they're just my patient. I'm the only one seeing them. It is a little bit, I know how I measure, so it's a little bit more reliable that way. If I'm sharing the patient, it is a little bit more subjective taking those circumference measurements. And I can definitely tell that when I'm sharing my patient with some of my colleagues, that we definitely do measure differently. So you kind of have to take that with a grain of salt. That, I mean, I think that L-Dex helps that because it is more reliable that way, that regardless of who runs it, it is a box and it's going to spit out a number. But I definitely do still take circumference measurements. Even pre-operatively, I want to know what is their normal, because their dominant arm could be bigger. They could have had an old injury. So I do want to know what their normal is and track if there's any differences. And it can guide you if their L-Dex score has elevated and you've got those circumferential measurements and you're reassessing those, you can tell where the differences are happening in the arm and you can track that and see improvements. So yes, I definitely do both. I run the test and I take measurements for sure.
What about you, Louise?
I think hearing Sarah say this, it makes me think about just the whole implementation of this model of care. And it depends where the model of care is being offered. Is it being offered in the multidisciplinary cancer centre, where perhaps it's not the lymphedema therapist taking all the monitoring measurements? So I know in some clinics that I've worked in that it could be a breast care nurse or an enrolled nurse or an allied health assistant who is taking the routine measurements, and there's a treatment protocol or a clinical pathway so that if someone triggers the need for early intervention, then there's a pathway in place to refer them to the lymphedema therapist for the measuring and fitting of compression garments and ongoing early intervention therapy. And so in that case, you might not have the facilities and the resources to take circumferential measurements. Whereas if you're offering the program within a physiotherapy department or a lymphedema clinic, you might have access to resources to be able to take all of those measurements. And remember too, that if you are running this model of care in your physiotherapy clinic, then you're also looking at cancer rehabilitation and musculoskeletal issues and scar management and the whole gamut of rehabilitation, which is really big now, and lymphedema is one aspect of that. So it does depend whether the model of care is being run within the large cancer centre or within physical therapy, physiotherapy sort of departments.
And Louise, we got an interesting question. I'm kind of looking through the Q&A. Can you talk about what's involved in actually taking an L-Dex measurement with the SOZO? How long does it take?
Sure, well, it doesn't take very long. I think the 30 seconds might be a little bit quick to do the whole measure. You have to get the patient to take their shoes and socks off, so it's sometimes a little bit harder in winter time, but they take their shoes and socks off. You have to weigh them first. So I have a set of scales next to the SOZO device, and then you stand them on the device. You have the option of putting the patient's profile, so their demographic details, into the device. You can put them into the tablet prior to the patient coming for the appointment. So if you've got those details, you can have them there. Once the profile's in the device, you just log on to the tablet, find the patient's name, and then you put their weight in. You can check that they have been to the bathroom and done those things that Sarah said earlier. And then you stand them on the device after you've wiped down the electrodes, and you put in the person's weight for the day and you press start. And within 30 seconds or so, the measurement appears on the tablet. And usually then you can show your patient. They're very keen. Often patients are very focused on their L-Dex numbers. And you can have the option of printing it out or printing the trended L-Dex readings out from the SOZO hub. But again, and I always write down the scores for my patients so that they can have them. And sometimes I have patients come into me and they say, I'm sorry, I didn't bring my little record of my L-Dex readings. I said, don't worry, I have them there. They're in the device, they're in the cloud, no problems at all. But they really like to have those readings. And I've actually found too that with some of my patients, getting that score helps to motivate them with their own self-management. So if the reading has gone up a little bit because maybe they've been a bit slack in wearing their compression garment, then a higher L-Dex score might motivate them to maybe put a bit more diligence back into wearing their garment or to doing their exercise or whatever self-management that they're able to do. So it's a start in a conversation about empowering an individual to manage their own condition. Because as I say to my patient, it doesn't really matter to me whether you wear the garment or not. It's not going to affect my arm, but I'm giving you tools to be able to manage your condition to try to prevent it from becoming a long-term problem. And I might have some patients who wear a garment, 2 or 3 days a week, or for particular activities when they know they're going to do heavy repetitive work, that maybe that little bit of added compression will just help to support the system and keep the lymphatic system in balance.
Yeah, it's interesting. We got a question from the audience. If either of you has experience with bilateral disease, especially over long term. It looks like we have an audience member who has kind of years apart in management. Do either of you work with bilateral patients, and do you manage them any differently from your unilateral patients?
I definitely do. Yeah, I definitely do see bilateral patients. It depends if they are diagnosed with bilateral breast cancer and have had surgery to bilateral lymph nodes at the same time. I'm definitely going to treat that different than the years apart. And I definitely look at how many lymph nodes are removed and if involved, and radiation treatment for that and chemotherapy. So I definitely have patients that 2006, they had a lumpectomy with 2 lymph nodes and radiation to the breast, and now it's 2022 and they've had bilateral mastectomy and a full axillary dissection on the opposite side. So on the L-Dex, I am going to put bilateral. I usually do that and put their dominant side, and then I'm going to track that. But I'm going to be more concerned about the newer condition or the more lymph nodes removed, and what treatment they're getting, if they're now getting chemo and radiation and different things like that. So again, as we've said a couple of times, it's that whole patient experience and what is going on with them at that time. But definitely, if they had an axillary dissection, even in the 80s, I definitely want to see what's going on with that arm and make sure that it stays stable, especially if they're going to use it for a PICC line or for IVs or with their surgery. So we want to look at the patient as a whole and treat them as a whole person, because lymphedema affects you regardless if it's from the original cancer or from a new onset or which side it is. So we are still doing that, looking at the patient as a whole.
Mm-hmm.
I agree with you, Sarah. Oh, sorry, I interrupted you there, Joanne. But I would say also that if someone has had a previous breast cancer and then a new cancer on the other side now, I've often found that the information or education they were given for that original breast cancer in relation to lymphedema is often not accurate now. Breast cancer management has changed in the last 20 to 30 years. Lymphedema management has changed considerably, particularly with the introduction of this model of care. And patients still come in really anxious about they can't do anything with their arm and they need to almost treat it in cotton wool, wrap it in cotton wool and not use it. And I know myself, when I was trained a long time ago, I'm almost telling people the opposite education to what I was telling them 25 years ago. And yet there's all these myths out there. So when someone comes in with a new cancer on the other side, we do have to start that education again to sometimes dispel the myths that they've had from their previous cancer. But definitely I would be managing them in the same way and treating them if they developed subclinical or clinical lymphedema on either side.
Okay, and those myths would be things like exercise and activities?
Yes, and not carrying really heavy weights and different things that we know now are really, they're not supported by the evidence. And we know that oncologists and surgeons get really upset with lymphedema therapists that we've created, a lot of anxiety amongst patients when really they do need to be able to give chemotherapy in that other arm. And I think we need to just be aware of what is evidence-based and inform our patients accordingly. Knowing though that we've got, I sort of wear a clinical hat and a research hat, and sometimes the two aren't the same. And so it's getting that bridge to educate accordingly to our patients.
Mm-hmm. Now we're getting to the top of the hour, and we had an interesting question in Q&A that I was holding out for you, Kathy, because you opened with the history of L-Dex, and we have a question about the future of L-Dex and SOZO. So What's in the future as far as ability to measure truncal edema and other parts of the body? Can you talk a little bit about what we can expect going forward?
Thanks, Joanne. I did see that question. So we're always looking to obviously expand what we can offer to help more patients. So we do plan in the future to be able to measure truncal edema. And there was a question about the breast as well. I think with the SOZO, the way it currently is, we could get to trunk and we could get to breast if we looked at different electrode configurations. So again, it's about really understanding how we can measure the fluid and how we can get to that particular time point. And breast edema is quite difficult. We've looked at, years ago, we looked at electrode arrays and things like that, but as the edema moves in or out of the breast, then that anatomy changes, so that makes it a bit more of a challenge to measure. But truncal edema is something that certainly should be achievable, but we don't want to put out a product that we can't stand behind. And the other thing I will say that the next generation device will have a scale, Louise, so you won't need to measure the weight separately. So that certainly is on the near horizon. So
Thanks, Kathy.
We do listen to our customers, Louise.
Thanks, Kathy. Any final comments as we wrap up the webinar?
Well, just on that point, I would say if you have any ideas and things that you want to measure, we do listen and we do try and work in what else is required. So please don't sit back and not let us know. We like to hear what we can do to improve.
Thank you. And Sarah, any final closing comments for our audience?
I think the biggest thing that just kind of came out of this that I heard was treat your patient as the patient. L-Dex is there. It's a tool. It's a phenomenal tool. It's greatly changed my patient care, but it's still the patient and you need to be patient centered. So take all the factors in on your patient and move forward from that.
Thank you, Sarah. And Louise, any final comments?
I guess for me, my vision, and after seeing this technology change, I've used now 3 bioimpedance devices over the years, that it's my vision that every individual patient who's diagnosed with cancer and is at risk of developing lymphedema have access to this technology on a routine basis that's covered financially and equitable to patients both in the city and the country, because we can now reduce the risk of lymphedema and the chronic long-term sufferings of those who do develop it. So we want to be able to get this out to everyone who's at risk.
Thank you, Louise. And I'll just close by saying thank you all for joining. This has been a very engaging discussion with lots of questions. We didn't get to every single question, and we will follow up with those who asked them. Thank you for sending them. Next week, a week from today, we have another event with a group of physicians to discuss the PREVENT trial. We have an investigator from the PREVENT trial reviewing results and 3 surgeons discussing the impact it will have on practice. That is next week at about the same time as this webinar. If you want to learn more about that, please visit ImpediMed's webinars and events page. Also, we will be sending some emails out. So if you get ImpediMed emails, you will see that come across your inbox. So thank you everyone for joining, and to our panelists for a wonderful discussion.
Thank you, Joanne.
Thank you.